OR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hey, we're back, and we have Patrice on the line from Brooklyn. Good evening.
Oh, good evening, Dr. Lederman. I wanted to ask you, please, I think you had mentioned that there is a segment of patients who had received a mastectomy.
Mm-hmm.
And on the patients who received mastectomy, in contrast to patients who didn't have mastectomy, I think the outcomes were not quite the same. But my question is, was that essentially because the patients who had mastectomies, they had a more invasive cancer? They had much more invasive cancer.
Well, the women in the study all had invasive cancer. It wasn't pre-cancer or DCIS. It was all invasive cancer, less than 4 centimeters, equal or less than 4 centimeters in size, with up to 3 lymph nodes positive. And they were equalized in groups. It wasn't a prospective study, so there are prospective studies as well, which take women and in advance randomly allocate women to lumpectomy and saving the breast or mastectomy. And those studies from the 1970s and 80s show equivalence. This study that was done had 132,000 women and actually showed markedly better survival for the group that had radiation than who had mastectomy.
Oh, okay. So there was better outcomes, as you just mentioned, but it was primarily because of within the parameters of what you just mentioned, obviously.
Well, just a minute. You're talking about 100,000 women with breast cancer 4 centimeters or less, up to 3 lymph nodes positive, and the group that had radiation and lumpectomy did significantly better than those who had mastectomy.
Excuse me, doctor, the women who had mastectomies, they did not also have radiation?
They did. Some had radiation. Actually, the group that had mastectomy and radiation did even it wasn't better for the women. So the point is really that radiation does not salvage difficult surgery or bad surgery. Lumpectomy and radiation had a 47% better outcome than mastectomy and radiation. So you can't just depend on radiation to save the day.
Yes, sir. I was just wondering, doctor, if I may please, in wrapping this up, so to speak, the patients who had the mastectomies, did they have a larger neoplasm or larger cancer? And this is why their outcomes were not as successful.
No, they looked at that. It was not that way. So.
Okay, doctor.
But it wasn't. But again, it was not a randomized study. It was a retrospective study, and that's the weakness of the study.
Okay.
But it certainly gives you an idea that women who have lumpectomy and radiation are not doing worse. And I believe that some women believe or led to believe that if you remove the breast, you'll get a better outcome or you're home free. And it's not the case. And I just want to reinforce that it's not the case. And there's no data out there for most women. I'm not talking about all women. For most women, there's no data out there saying mastectomy is better than lumpectomy and radiation.
Thank you so much, doctor.
All right, God bless you, and thank you for calling in.
Thank you.
And I wanted to also talk about another disease that affects women, and that is ovarian cancer. Now, ovarian cancer, unlike breast cancer, is a cancer that isn't so easily diagnosed. It's not a lump, and it's not a mammogram-detected disease. The ovaries are deep in the pelvis, and often they can become cancerous before symptoms, and often they can even spread to stage 3, which is metastasis in the abdomen. So it's a big challenge for women. It's a big challenge for the medical profession. And guess what? Here's an article from the Journal of the National Cancer Institute. It's another prestigious journal. And I'm quoting from an article by Charlotte Bush, this month's journal, saying aspirin use was associated with a reduced risk of ovarian cancer, especially among daily users of low-dose aspirin. Wow, this isn't the first time we've heard about aspirin reducing the risk of cancer. This is a study from 12 population bases of ovarian cancer with 7,000 patients and with 11,000 controls. So the controls were the women without ovarian cancer. The 7,000 patients were women with aspirin, with ovarian cancer. And those who took aspirin were more likely to be cancer-free. And it was about 20 to 34% more cancer-free depending on the frequency and the dose of aspirin. So regular aspirin use was defined as once a week, and that occupied about 18% of the population. The authors said that there are obviously complications of taking aspirin, peptic ulcer, bleeding, hemorrhage. Those are the downside, but that aspirin will reduce, on average, by about 34% ovarian cancer in women taking that 81 milligram pill every day. So it's interesting news, and it may be something that you want to take not only for your heart, but also to try to prevent ovarian cancer. And again, that reference was the Journal of National Cancer Institute, and it was out this month. And there's one more article, a research article, that pertains especially to women, and it looks at survival being poorer in women whose treatment is delayed. And this study was from the Journal of the Clinical Oncology from the University of Texas, and an article by Matthew Stenger assessed the association between the time of adjuvant treatment and survival in breast cancer patients. And the researchers found that a delay in therapy is associated with significantly poorer overall survival in all patients. So it's another study that looks at why do some people do worse than other people? And delaying therapy is not helpful. Why is that? Well, it may allow cancer to keep on growing even after, let's say, the woman had lumpectomy. We know that there's a significant chance of cells left in. If women wait 30, 60, 90 days to start treatment, that may give the cancer a head start. The study involved almost 7,000 women with stage 1 to stage 3 breast cancer diagnosed between 1997 and 2011, undergoing treatment in Texas. And they looked at the initiation of treatment at less than 30 days, 31 to 60 days, and more than 61 days. And they found a significant higher rate of death in women who delayed treatment. So the authors concluded, we demonstrated that delaying the initiation of treatment was associated with worse breast cancer survival outcomes, and the clinical impact varies upon the stage and the subtype of cancer. Early initiation of adjuvant treatment is particularly relevant for patients with advanced breast cancer diagnosis, those with triple-negative breast cancer. The adverse outcomes occurred when treatment was delayed more than 61 days. So, again, if you're diagnosed with breast cancer or other diseases, prostate cancer too, studies have shown an increased mortality in people who delay treatment. So please don't delay. We have something in our office called the Urgent Cancer Consultants, where we promise to see patients within one business day. And we do that just so we don't have the delays like we saw in this article. So it's really important to get to your doctor promptly. You're welcome to call us. We take the calls during the week at 212-CHOICES, 212-CHOICES. I have a patient I want to talk about now, a man who came in this week. He is a 65-year-old man, Hispanic man, was born in Dominican Republic. He, in 2012, had a PSA of 7.9. Remember, the PSA is prostatic-specific antigen. He had a biopsy in one of the big hospitals. He was found to have a Gleason 6 cancer, 3 plus 3 equals 6. Gleason is how the cancer appears under the microscope. Pathologists take two areas and give it a number from 1 to 5. 1 is the best, 5 is the worst, and then add it up. So 1 plus 1 equals 2 is the best, 5 plus 5 equals 10 is the worst Gleason score. This man had a Gleason 6, which is right in the middle. And then he never had treatment. He never had treatment. He has urination 3 times a night. He stopped drinking water after 7 p.m., stopped drinking liquids, and yet he didn't get treatment. He heard about our program. I saw him. I sat down with him. I examined him. I got his records. He had a markedly enlarged prostate. It was a Gleason 6, and now his PSA is up to 14. So he went in that interval between 2 years ago when he had a low-risk cancer, which means the highest chance of being cancer-free, to intermediate risk. Intermediate risk, if you open our booklet, and our booklet on page 16 is page 14 in our prostate book, and we're happy to send you this booklet at no charge. This looks at data for intermediate risk men with prostate cancer, meaning Gleason 7 or PSA 10 to 20. So if he went to, and this graph shows the results of 2 major hospitals, one in Boston, one in Philadelphia, and their results. Their best results for him are about 60%. Our results are 90%. And we do treatment in about half the time of usual radiation. And we believe we're better because we're able to use the stereotactic frame, and we use brachytherapy, which boosts the dose of treatment to the prostate. So we believe we still have a 50% better chance than the other guys. We believe most likely he's going to be cancer-free with a good quality of life, even though, unfortunately, he delayed 2 years to come to us. He did come to us, which was one good decision. And number 2, he chose to get treated with us, which is another great decision. So he started therapy. We wish him well. And, again, we'll report back to you as time goes on with this gentleman. We're going to take your calls. We're at 800-321-0710 if you wish. And in the meanwhile, we are going to hear from our sponsor, the man with the golden voice.
Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board-certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Okay, we're back, and we're taking your phone call. Good evening.
Good evening.
What question? Go ahead.
I'm calling about the low doses of aspirin taken by women daily.
Yes, daily. 81 milligrams. Reduced ovarian cancer by about 30%.
Okay, that's good to hear.
Okay?
Yes, thanks.
Okay, God bless you, and thank you. Bye. So we had a gentleman come in this week who is a 70-year-old, and he came in with a big mass on his shoulder the size of like a fist. So I sat down, spoke with him, and got his history. He's had this growing and mass there for about 18 years, soft, fleshy. And then I examined him.